So I have the great pleasure of announcing today's speaker, Jane Kennedy. She is a certified nurse practitioner, and she's going to present on the topic, identifying the effects of hormones and metabolism on psychological states through the life cycle, or throughout the life cycle. Jane has concentrated her Santa Rosa clinical practice over the past 18 years on helping women and men regain their health and vitality after experiencing hormonal imbalance and decline. Her extensive training and experience with experts in the field of integrative and functional medicine have made her into a leading hormonal health practitioner. Trained as a nurse practitioner at UCLA, Jane has been in clinical practice for over 40 years in family practice, women's health, and dermatology. With an additional master's degree in public health, she has always focused on disease prevention and embraced a mind-body-spirit model of health. Thank you, Jane. Come on up.
I really look forward to this time we're going to spend together because this is a topic that I am passionate about. I've never worked in the field of medicine in an area that I had more sense of accomplishment and self-satisfaction because of what my patients are able to do. Thank you. Yes, that's who I am, and hopefully you saw on the back table that there's a handout for this talk. If you didn't get one, you could slip back there right now, but it's the kind of handout you can put in the things that are important to you. Also on the back table, you'll see newsletters that we'll talk about later. You can access those on my website also. So here we go. On my website, you'll see this banner, and the picture to the left, where you see the stones stacked up, is one of my brands, because to me, hormones are all about balance. It's how we create balance in our lives that's what gives us the optimal health and vitality that I think each of us are looking for. Just a preview of what we're going to go over today. I'm going to briefly tell you my story and how I got into this, talk about functional and integrative medicine and how those approaches might be a little different than some of the typical medical approaches. We'll look at some case studies, and I'll be asking for you to think of some in your practice. We'll look at statistics on depression, anxiety, cognitive decline. We'll look at the major sex hormone players, who's up here for men and for women, and other hormone players beyond the sex hormones, and how these all play together to make an orchestration of balance in the body. There are also metabolic factors we'll be talking about. Hormones through the life cycle then of women and men. We're going to take decades of the life cycle and look at what's most commonly out of balance and potentially causing psychological imbalances for patients. We'll look at the causes of disruption, the symptoms, the possible testing, and treatment options that are available. We'll come back to our case studies, and I'll share some clinical pearls with you of what I see with patients in my practice. And then we'll end with discussion, and we're going to keep moving but to cover all of that. So my experience is that about 20 years ago, I was a clinician in dermatology, and I was the chief financial officer in that practice. And what I had been doing with little effort at all to create financial reports on a monthly basis, understand them and make sense of them, was no longer working. I was sure that I was coming down with early Alzheimer's because I couldn't make it work in my mind. And that set me off on a path of really digging in to understand what was happening to me at midlife. Yes, I was highly stressed. I was about to go through a divorce, which I never recommend to my patients when their hormones are out of balance. But I did, and I fortunately met up with a physician colleague at a lunch meeting, and she said to me, "You need to look into bioidentical hormones." Well, I was a little put off because my mother had breast cancer, and she died 18 years later of cancer that we weren't sure about the origin. And I wasn't sure that was for me. But I took her advice because my life was falling down around me and was not functional. And I got in and I studied. And what I found, I want to share with you today, plus current literature that takes it to an even higher level of assurance of what we can get from the use of appropriately prescribed hormones. And I decided to cut my risk for breast cancer with my lifestyle practices. And I have done that for the last 18 years. My sister has done that too. And I am so glad to be in the place where I am now, where I feel my life is in balance. I'm holding my chronic diseases at bay. I am not in a fearful state, and I want to help you get an understanding of how you can come to grips with what options are available so that you can help your patients in their decision making. So, from the perspective of the philosophical position of integrative and functional medicine, as a clinician in that type of practice, I want to look at the patient in front of me, and I want to ask, is this just depression or anxiety, or what might there be as a physical, biological cause behind that that I need to be aware of? And then asking myself, what is it do I really want for my patient? It takes time to listen to patients, to hear the whole perspective of what's going on in their lives. That's what integrative and functional medicine specialists do. That means we spend longer appointments with patients, and oftentimes insurance companies don't want to pay for that, so that's why many of us have to go to being cash-based practices. The integrative approach looks at the whole person, the mind, body, spirit, the environment in which that patient is in now and which they grew up in that led them to where they are now. And we look at relationships and what's going on with that person overall. We want to co-partner with the patient. We're not there to tell them what they've got to do. We're there to be their partner in educating them, motivating them, and helping them to get the health outcomes they're really looking for. In functional medicine, the approach is to look at the underlying imbalance that's going on with that individual, and then to find the treatment approach that will cause the least amount of side effects and disruption for that person as we help them get back to optimal health and well-being. That's the natural body balance. I often say to patients, you know, your body's much smarter than I am. I will do my very best to help you get back into balance. But we've got to bring the wisdom of your body to the table here too, because that's what's going to guide us in what's going to be best for you. Because in integrative functional medicine, we're looking at each individual patient. We're not just giving a cookie cutter of what's going to work for everyone to each person. And that's all about recreating balance for that individual in their life. All right, so now here's the point where I need the microphone, where I want to work sort of quickly here. But I'm wondering if in your practice you have any patient that maybe is having psychological symptoms that you wonder might be from hormonal imbalance. If you'd give me an age, a sex, and just a few symptoms, I'd like to write it up here. And as we go through this morning, I think you'll begin to get a picture of what might be going on. And we'll come back to this at the end. Anybody? Yes, go right ahead. 28.
Female. Postpartum. Severe depression.
All right.
Close to suicidal ideation.
All right. Great, that's enough. So let's go to the next person. Thank you very much. Next person.
Okay, this adds in another dimension of hormones. So this is a 30-year-old trans male on testosterone, and with those adjustments.
Okay. Next.
73-year-old, obviously postmenopausal, sleeping issues, almost lifetime. low sex drive, anxiety.
Great. Was that a male or a female? Okay, thank you. Next.
This would be a 60-year-old female. Lots of irritability and anger, mood shifting, impatient, and feeling just unhappy with her life.
Okay, great. That's great. If anybody has a burning case, let's take one more.
Age 40, female, symptoms of, she's a post-eating disorder in her, cured at age 20, and
A post what?
eating disorder,
Okay.
and rigid thinking, paranoid feelings, high anxiety.
Great. Thank you. Okay. Very good. Thank you. All right, so we'll come back to those a little bit later. But for right now, let me share a case with you. This is a 44-year-old female with intense PMS and heavy menses since her last pregnancy 4 years ago. She complains of low libido with vaginal dryness, anxious and not sleeping well with hot flashes, is quite moody, irritable, non-motivated with cycles of depressed moods. Her marriage is challenged. She's 20 pounds overweight, eating a diet mostly of high carbs with little exercise, high stress with her job. This is a typical perimenopausal woman coming in to see me. We'll come back to that. So what does the literature show us about psychological symptoms that are related to hormonal imbalances? Well, the first one here is from the Archives of General Psychiatry, 2008. And I just want to say, I'm just going to give you a summary of a few sources here. There certainly are many, many more. But I just like to throw a few up here so we're reminded. Yes, there are scientific articles that show that this is a real phenomena. Concentrations of sex hormones associated with various measures of well-being. Depression, listed by the World Health Organization, is a leading cause of ill health and disability worldwide. Premenopausal women with no history of depression who go into perimenopause are twice as likely to get depressive symptoms as women who stay out of premenopause. They can't stay there forever, but Then the association of hormones and menopausal status with depressed moods is common within menopause. And postmenopausal women in this study showed that their anxiety and depressive symptoms were relieved with micronized progesterone. We'll look more at some of that treatment. 1 out of 5 women experiences depression as she moves towards menopause. The lifetime incidence of mood disorders in women is twice that of men. Yet men have a 30.6% rate of depression in their lifetime, with them having a higher suicidal rate than women in the U.S. So it's not just women, it's men and women that are affected. Low testosterone affects both men and women, and a decrease in sexual desire has often been used as a descriptor of depression. And oftentimes, then, it's easy to go into treating the depression, maybe with a medication, without stopping and thinking that that particular medication may be depressing the effects of their hormones even further. A question I like to ask is, why not treat both the symptoms and the cause of the symptoms by looking at their hormones and seeing if that might be an indication for imbalance? And then that question is, what really helps the patient? Here's another article, this one on men, where they studied almost 2,000 men on testosterone treatment, and they found that they had a 50% reduction of depressive symptoms, especially the men who are treated on higher doses of testosterone. And that's something we'll talk about because the amount of these hormones that are used, we don't need them back at the levels where we were in our early 20s and 30s. But we do want to get to optimal values to get the full benefit for patients who are undergoing therapy. Here's some other points from the New England Journal of Medicine in 2004, Psychiatry and Journal of Family Practice. DHEA can be helpful in controlling minor and major depressive symptoms. Estrogen can be preventative of depression, so can, and I'll throw up there, so can progesterone. Testosterone deficiency has symptoms of depression as well as loss of vitality, and many other symptoms we'll cover in just a moment. So there's some myths about menopause that I'd like to make sure we address here. You know, from the Middle Ages, the concept was that women were going through this period of their lives and they were sinful and unclean. And though that was the Middle Ages, some of that's filtered into the 19th and early 20th century. Even up to the 1960s, there are voices thinking that and saying that about women. Women were felt to be at the end of the usefulness of their lives because their fertility had come to an end. And it was often referred to, this emotional state that they were in, as hysteria. And that diagnosis was given quite frequently, and many women were put into psychiatric institutions based on hormonal changes that happened to them. If you think back in your family history, like I have, you may come up with identifying women in your past who were put in psychiatric institutions, who it looks like it really was from hormonal imbalances. That was the case with my great-grandmother. I'm almost certain of it. There are other hormones that affect psychological symptoms in patients that we need to be aware of, that are also affecting their sex hormones and vice versa. One of those is the thyroid hormone effects. You know, there can be low thyroid and subclinical levels of our active T3 hormone that causes depressed moods, causes depression, even to the point of suicidal depression. The current lab ranges that are touted as being normal are really don't account for the individual needs of patients and where their hormone levels need to be. So as trained and experienced clinicians in this area, that's something we take into account. And we'll talk more about testing a little bit later. The typical evaluation that most patients go through for their thyroid, assessing TSH and free T4, are really inadequate. Those don't give a full picture of what is happening to the patient with their thyroid. And the standard treatment that we often see with Synthroid almost always misses the boat as to the real issue of how to get this person out of hypothyroidism, out of possible depression, out of suicidal tendencies. It's interesting as you look at the diagnosis of bipolar disease, two major studies showed that 69% of patients with this diagnosis are misdiagnosed initially, and a third remain misdiagnosed for 10 years or more. The average bipolar patient has been on 14 other medications before they try T3. But once T3 is initiated, 84% saw improvement and 33% with full remission. These hormones are related to the psychological state of many of us, and we can't forget that. All right, so what do we do with all this information? We've got these imbalances. Where are we going to go with it? How are we going to approach the patients that sit down in front of us? Well, the major sex hormone players for women and men are the same. Shock you? No, hopefully not. They're the same, but at different proportions. For women, the priority is estradiol, then progesterone, then testosterone. They actually make more testosterone than estrogen based on amounts over their lifetimes. But it's the proportions that are made at certain times that make them women. Men, of course, it's testosterone, progesterone, and estradiol. Beyond those sex hormones, though, other players that are affecting the moods and the psychological well-being of patients include the adrenal glands, The adrenal glands are what make cortisol to keep us dealing with stress effectively. And if they get so tired out they can't function, you know what they do? They steal the sex hormones. It's one of the primary causes for young women to go into hormonal imbalances. So the adrenals are major players in disruption. Then the thyroid, which from stress and the toxic environment that we're subjected to, it's felt are two of the major causes. We're seeing low thyroid at epidemic numbers now. Insulin and glucose metabolism. Sometimes we forget that insulin is a hormone, and patients who are dealing with this issue often have psychological implications, and we'll talk more about that. Neurotransmitters, serotonin, GABA, dopamine, all of those can be other hormones that can be contributory. The gut, well, that doesn't sound like a hormone, does it? But let me tell you, the gut is essential for the metabolism of hormones so that they don't get stuck in the body and we get overloads of hormones in the body. The liver is an important part, and our genetics play a role in that. So all of this needs to be evaluated. Cholesterol, all the hormones are made from cholesterol. What happens if you drop the cholesterol with the fad of giving everybody statins now? They can't make hormones. Okay, so we're not really helping these patients if we're not careful here. Vitamin D is a player. Sleep affects this. Lifestyle and preventative practices also are going to come into play beyond just the sex hormones. So let's turn now to the women and the life cycle of women. What are the hormonal imbalance that we see at different parts of their lives, and what kind of symptoms are showing up? Well, from the teens to the 20s, there's usually, they start off with low production and often have imbalances in their sex hormones. Commonly, that's affected by stress in a negative way. And I've had college students, young women, who had so much anxiety that they could hardly function because of the stress and the hormonal imbalances being caused. Depression is another one there. Oftentimes, these young women are just put on birth control pills. And I would say, stop a minute, take a look at what birth control pills really do. On my website, there are newsletters that I write usually every month or two. There's some on the back table. And in the past year, I just wrote an article on the effects of birth control pills on the hormonal status of our body and what they can do. So there are other options beyond birth control pills, though in some cases they do play a valuable role. During the childbearing years, there can be infertility because of these hormonal imbalances. That's sex hormones, that's thyroid, that's adrenals, that can all play into infertility. When pregnancy happens, the production of hormones tends to go down dramatically after every pregnancy. This is often a time when low thyroid starts for many women after they've been pregnant. The high stress of caring for a newborn, maybe having additional children, makes it so their sleep is interrupted, their adrenals get affected in a negative way, they get depressed, and the adrenal fatigue issue is almost a given for any young mother. At perimenopause, which I'll point out, this can start in the early 30s to mid-30s. And now the usual time of perimenopause is in the early 40s. It's not when our mothers and grandmothers were, ladies. It's earlier, and the thought is it's the stress and the toxins that we are exposed to now that's bringing that to an earlier time. Of course, when perimenopausal symptoms start, it's a lowering of the sex hormones. That can happen in the 20s. At that point, we diagnose it as premature ovarian decline. But it's the same kind of thing that's happening in perimenopause. Hormones are declining and getting out of balance. So perimenopause will come early the higher the woman's stress level is. Intense PMS, changes in menses, emotional upheaval, and we'll get into some of the specifics of the symptoms and how we can differentiate. In menopause, the 40s to 50s, many women will come in and sit down with me and they'll say, I don't know who I am anymore. My personality has changed. I'm this irate, irritable woman. I never used to be this way. What is going on? We see irritability, anxiety, depression. Yes, I put the term bitchy up there because this, I think, is where the origin of that word came from. Perimenopausal women. And it's usually because estrogen's too high and progesterone's too low. They're irritable at everybody, and usually they're the ones that have at home the teenagers who are going through hormonal fluctuations also. It's just a dynamic you can't believe. I want to point out that menopause isn't a disease. It's just a process that women go through in their lives, and it will be different for every woman. Some women have extreme symptoms and others have no symptoms. That doesn't mean, though, that the information that we're looking at here can't be beneficial to any woman going through menopause. In the elder years, for men and women, the body's natural tendency is to become neutral with its gender. There's less hormones made. There's often a loss of zip and energy for us as we're getting elderly. Chronic diseases are prevalent, which I should point out start in the menopausal and andropausal phases when the hormones start going down. The changes in the body that happen in the elder years often make it more difficult for patients to have sexual intimacy, and that's another factor for them. All right, that's women and what's going on for them. Here's case study number 2. 26-year-old female, she can't get pregnant. High stress, PMS with severe cramps, heavy bleeding, flooding her bed at night, gaining weight, anxious, highly irritable most of the month, and crying a lot. On testing, we see that her estradiol comes in at 340. That's the major estrogen for women, and during the cycling years, it should be between 250 and 500 as an average. So she's in that range. Her progesterone, though, is at 3. Progesterone at this point should be somewhere between 10 and 25. So you can see she has low progesterone at this point in her life. Total testosterone is 45 and should be 40 to 100 or more. And her free testosterone is like the cells don't have any testosterone available. That's why she's crying all the time. We'll come back to this case a little bit later. All right, so for men, what's going on for men during their life cycle? Well, in the teens and 20s to 30s, there can be genetic influences that affect how much testosterone their body is producing. That can cause different developmental issues for young men. There can be high stress that has an impact also, and toxic exposures and chronic diseases. I'll have to say that in the younger men, the toxic exposures usually are the top of the list as to what's going on as a cause. In the mid-40s, most men will start going through andropause. That's the male corollary to menopause. And a lot of men will just sort of blow it away like it's just aging, nothing big is going on. They'll experience more lack of motivation. The muscle mass may start declining. They can't go to the gym very much. They're not motivated to go to the gym very much. Life can be flat all the way to depression, clinical depression for these men. Sexual dysfunction can get started all the way from loss of interest into the field of erectile dysfunction. And I'll point out that in the male body, as they're going into andropause, testosterone production is coming down. But the natural physiologic effect in the body is for estrogen production to go up. And that's a critical factor in what gives men a lot of risk for chronic disease. Everything from cholesterol getting out of balance, glucose getting out of balance, gaining weight, the list goes on. Estrogen is not men's friend at high levels. In the 50s and upwards for men, chronic diseases continue in their development with the weight gain and limited mobility and mental decline for many as the testosterone goes down. Again, it'll be individual. Each man will be different. I've had men in their 80s who have just a small amount of decrease in their testosterone. So it can be variable, though I don't want to paint the picture that that's the usual midlife male. So here's case study number 3. A 35-year-old male presents with fatigue, insomnia, high anxiety, declining libido, though he's newly married and very much in love with his young bride, losing erections, losing cognitive edge, not able to build muscles at the gym. His total testosterone comes in at 312. That's low for men. But his local HMO doctor told him, that's a normal level of testosterone, you're fine, it's all in your head. I can't tell you how many times I have patients present like that, and it's really sad. But I'm glad he came. The free testosterone for him is 1.4 and should be well above 25 with this method of testing. FSH came in at 4. So FSH is follicle stimulating hormone. We use it sometimes in our evaluation for men and for women because it's telling us what the hypothalamus is doing, because there are different places where dysfunction can happen. And FSH is sometimes reliable. If it's elevated, it tells me that they're in andropause or they're in menopause. But if it's low, it may just be the factor that FSH is an old factor for looking at hormone balance. Excuse me. And it can be 10 to 15 years off what the actual hormones are really doing in the body. So what are the causes of all these imbalances? Why are we seeing this happen? Well, it's a change in production, and that can happen from the aging process, certainly. But there are other factors that can be at play here. One of the biggest ones is stress. The more stress we're under, the more hormonal disruption there is in our bodies. Illness and infection can also be factors. Anyone who has a chronic illness, they're not going to be producing hormones at the level that someone that's well and vital and alive, well, everybody's alive, I guess, but well and vital is going to have. You know, I worked for a period of time in a chronic disease practice, and I was there to help those patients with hormones because it's a given fact that hormonal imbalances can be factors with things like fibromyalgia and chronic fatigue and Lyme disease. And those patients need help with hormones also. Genetics play a role, diet, exercise, and toxins. All of these are factors that may be contributing to the imbalances that we're seeing in our patients. So then I want to differentiate between this primary and secondary cause of hormonal decline, particularly if I'm dealing with a younger person before the changes of aging would kick in. The primary dysfunction with hormones is when the actual organs that should be producing the major sex hormones are not doing the job. So the ovaries, the testes, they're not doing their job correctly. That's a primary dysfunction. A secondary dysfunction is when the hypothalamus of the brain is not picking up and realizing that there are deficiencies of these hormones and giving stimulation to those target tissues to go ahead and make more hormones for the individual. Now I want to turn a little bit to the specific sex hormones and look at some of the symptoms that we can expect when we see deficiencies and declines getting started in our patients. The first is progesterone deficiency. And we see this particularly in women. It may start, like I said, in their late 30s, early 40s, and may last for a year or two, up to 10 years. Many young women do not realize that their symptoms that they're experiencing are really from low hormones. But some of those symptoms that you can help them identify can be nervous tension, mood swings, irritability, anxiety, cramping with their menses, bloating, pain, particularly with the menses, depression, insomnia, breast tenderness. These are all symptoms that can show progesterone decline. Now, it gets a little more complicated because some of the other hormones being out of balance can have some of these same symptoms. That's why we want to be doing testing with patients at some point. But these are the major ones. When I think of progesterone decline, I think of bad PMS, anxiety, and depressed moods. When estrogen starts to decline for women, it's later, closer to menopause. That's when hot flashes start. It's not an early symptom. They've already been in perimenopause for a few years before the estrogen is declining. But for men, they can have hot flashes too. That may surprise you, but it does happen, and that's usually with the decline of testosterone for them as their primary hormone. Many times women will have the hot flashes, the memory loss, low libido, change in their orgasm, saggy, dry skin, the irritableness, the bitchiness that I mentioned previously, the weight gain, bladder issues, dry vagina leading to pain during sex. These are very common kinds of symptoms as estrogen is declining for the women that we're working with. Testosterone decline includes the strength decreasing for men and for women, muscle decline, muscle mass will start to shrink, weight gain is common, chronic disease gets started. In fact, I want to point out that it is at midlife for women and men that chronic diseases start to get a foothold. The hormones help to keep us from developing chronic diseases, and so when they start to get out of balance, that's the opportunity for chronic diseases to get going. And that can be from cholesterol to glucose to diabetes to heart disease, all of those, and we'll talk more about that in a minute. Decreased ability to stay focused, that's a common one. Less assertiveness, depression, flat affect, lower libido and erectile dysfunction for the men. Take a look at this photo on the left here. This is a famous actor. The photo on the left shows optimal testosterone for him. You see his face is clearly, to me, he has plenty of testosterone in his body. Then take a look at the left. What difference do you see? There's a fullness, a fatness to the face. That's an estrogenized male when that happens. So right there with that young man, I hope he got some testosterone. All right, so beyond sex hormones, the thyroid, what kind of symptoms are we going to see there? We're going to see a lot of fatigue. We're going to see insomnia, anxiety, depression. These are people who can be suicidal, and I've seen it, and I've seen T3 given at appropriate levels, and they get out of suicidal depression in a few days. Now, I can't say that's for everyone, but for some patients, that is true. The adrenals, we're going to also see fatigue. We're going to see anxiety, insomnia, depression, loss of motivation. Fatigue is a big one when patients are faced with adrenal fatigue. Insulin and glucose dysregulation. These patients tend to be more depressed. They're more sluggish cognitively. They have a lot of moodiness. They'll be high energy when they're eating and getting the effects from glucose, and then they're going to crash when that's gone. And cravings abound, and often these individuals have weight gain around the middle. And what sets that up? Well, lowering testosterone will be a major factor for this to get going for these patients. Neurotransmitters, you know about these: serotonin, GABA, dopamine, insomnia, mood changes, a lot of sadness, anxiety, and depletion. Sometimes we need to be checking neurotransmitters. Human growth hormone I put up there because it's involved in the aging process. And muscle decline, fragile skin, weight gain, depression is common with lower human growth hormone levels. And I'm here to tell you that it can be utilized safely with clinicians trained in knowing how to do that with patients. But a couple criteria I have for patients is, if you're in relationship with someone, I don't treat you unless you both do it, because one will get almost younger, and the other one will continue their aging, so I don't think that's fair. And then the other one is that I feel like it's well known that you need to get your sex hormones balanced first, or you're wasting your medicine or your money on human growth hormone. And you need to be willing to cut alcohol out of your lifestyle completely, because alcohol just burns up human growth hormone in our bodies. How many people end up coming to me for human growth hormone after I say that? It's expensive. But there are other things that can be done. There are peptides now that can be done to help with human growth hormone. So there are other options. Methylation and Lyme, both of these areas can have implications for sex hormones. Methylation is the major detox pathway of the liver. It's a genetic issue that some people have that needs to be addressed. And Lyme disease can really pull hormones down also. Testing. I'm here to tell you every test is perfect and every test is imperfect, okay? There's a place for every kind of test and there's a place where it will fail you. As a clinician, I've had to learn this over the years of practice, and what I can tell you is I use every form of testing, but I'm looking at my individual patient sitting across from me and deciding, is serum blood testing best, intracellular blood testing, saliva, urine, stool testing? What does this individual need right now? And also the timing of when the testing's done and the preparation for that testing is important. I just, one last thought there. I particularly feel that it's important to understand when testing values come back from a Western medicine lab, they're going to give you a normal range. You need to understand that that's a statistical bell curve, and there are a lot of abnormals within that range that they're giving. In integrative medicine, it's been felt for decades that that isn't good enough for our patients. We want a higher bar to assure quality of life and well-being. And so many studies have been done to determine optimal values for each test and at each age group and each sex as to where we want our patients to stack up, to know they're going to have the best quality of life, decrease their risk for disease now, and cut their risk for the future. And that's what we use in integrative medicine.